Hi everyone, hope we are fine. In this case, what we want to be thinking about is the second stage of labor. And it is important for us midwives to understand the second stage of labor, how we can manage it, and what are the signs and symptoms that leads to the second stage of labor. What we mean is when we're talking about the second stage of labor, this is the stage of labor in which we are going to have the full dilatation of the cervix, that is 10 centimeter. 10 centimeters full dilatation of the cervix, and ends with the delivery of the baby. So we are going to have the delivery of the baby. Now, how do we manage this second stage of labor? Well, it is important for us midwives to understand this, because if we can manage this second stage of labor properly, then we are going to prevent such complications such as postpartum hemorrhage, intrapartum hemorrhage, and that is very important for us to notice as midwives. We are going to prevent all sorts of complications such as fetal heart distress syndrome, all those kinds of complications, asphyxia, and all those things may come as a result of our ignorance in the management of the second stage of labor. So we need to have a background physiology of the second stage of labor in order for us to manage it. Now, we have already talked about the background physiology, the physiology of the second stage of labor. What we want to focus primarily in this talk is how we can manage the second stage of labor in a way that we will not be able to forget easily. And it is supposed to be at the tip of our fingers. So, what do we start with when we are talking about management? As we know always, we are going to have our aims. So, what are the aims when it comes to the management of the second stage of labor? So our aims will be: number one, we want to prevent any complications that may arise as a result of the second stage of labor. We want to prevent complications such as asphyxia, distress, both maternal and fetal. And also one of our aims will be to provide an optimal birth for the mother. And also we want to manage the woman in the second stage of labor psychologically. We will allay anxiety as always, because the second stage of labor is accompanied by regular and more painful contractions. So we want to allay anxiety, because the pain is going to be even more as the second stage of labor progresses. Those are just one of the aims. You can make a lot of aims out of which, but all we want is in this talk, we just want to focus on the things that we will not be able to forget easily. Environment. Light. Environment. So what is the environment where we are going to nurture this woman who is in the second stage of labor? Of course, we want the environment to be clean, and we want the environment to be free from noise, free from any disturbances. And one of the most important thing is we want this environment to have all the equipments that are needed in case of any complications. So we want to have all the necessary equipment for emergencies that may arise in the second stage of labor. So for example, we may have the baby born with CPD, and CPD is a cephalopelvic disproportion. usually the baby's head is going to be bigger than the passage. This is what we call the passenger is the baby's head, and the passage is the mother's vulva. The mother's vulva, that is where the fetus is going to pass through. And we may have cases like this. So we need to have equipments that are going to be needed in order for us to perform an episiotomy in case need be. As always, we need privacy. That is under our environment. Right? Environment. Coming to position. How do we position this mother in labor? So as always in labor, you are supposed to press or position the mother in a lithotomy position. And of course, the lithotomy position this is the lithotomy position. The lithotomy position, what will do, it will allow you to have a full view of the vulva area. And in that position, you are going to be able to detect the fetal heart, the contractions of the uterus. You will be able to palpate them easily. And you'll be able to do the vaginal examination as without complications arising. So a lithotomy position is very, very important. Now, the other thing that you need to consider is that as well as lithotomy position, there are also other positions that are preferred in labor. In case the woman prefers one of them, you are supposed to let the woman lie in that position. But amongst the positions that are preferred besides this, there is what we call the dorsal position, where the woman lies on her back also. That is the dorsal position. You can also allow the squatting position of the mother. All those positions are going to be used in the labor ward, and in case the woman needs one of them, because what we need is the mother's interest. And after that, I think we'll do observations. Now, observations, what we'll do in observations is we will observe both the mother and the fetus. So what we will start with is under observations is maternal observations. So this is maternal observations. And the way that we are bringing up the points, that's the same way that the points are supposed to be even brought out when you are having your exams, your final exams. So, maternal observations. What is it that we are going to observe on maternal observations? Of course, we are going to observe the uterine contractions. So, we have so you observe the uterine contractions. Are they strong? How long do they take? Durations. Are they regular or irregular? You are going to observe all those things. And also you are going to observe for friction, descent, rotation. You are going to observe these because all these are the cardinal movements that are taken by the baby as it passes through the mother's birth canal. The other thing that we are going to observe is now bladder. As the fetal head descends, the bladder is more vulnerable to damage. So it is important for us midwives to keep in mind that we need to observe the bladder, because the bladder is vulnerable to damage as the fetal age descends, especially if the bladder is full. So what we do is when the bladder is full, we observe this several minutes after, or 30 minutes. If it is full, then you can allow the woman to void. You can't tell the woman to leave the bed. Of course, you are supposed to provide a bedpan as a midwife. And if the mother is unable to pass urine, you can insert the catheter on the woman. Very, very important that the bladder is empty during the second stage of labor. Now, as well as that, we are going to observe the maternal comfort. Still on the maternal observations, we have accounted for uterine contractions, we have accounted for flexion, descent, rotation, bladder, and what we want to do still on the maternal observations is we want to observe the maternal comfort. So maternal comfort. Now, labor, the second stage of labor, in fact, the whole process of labor requires what we call energy. It is a metabolically demanding process. So as the woman is giving birth, as the woman is pushing, then there is no doubt that she's going to be sweating. And also there is no doubt once she sweats too much, there is going to be thirsty and she's going to be dehydrated. So what we do is we'll observe maternal comfort. If she's sweating too much, then we are going to tepid sponge her. You are going to tepid sponge her. If she is dry, you provide some moist lotions on the lips and give her some ice cold sips. Sorry. At least she sips a bit and she will be feeling okay. So we observe maternal comfort. If she's dry, if she's having dry lips, then you provide some moist Vaseline or some lotions on the mouth. You give her some water, some ice cold sips she takes. If you have got some glucose, sorts of things that will give her energy, you can give her. The other thing that we are going to observe is a maternal condition. What is it that we look out in maternal condition? Of course, here in maternal condition, we're going to do BP, we're going to take pulse, we are going to take all the vital signs that are needed. And that is done every 30 minutes during this second stage of labor. So we do all those things and we are going to record them. Still on maternal observations, we are going to observe our psychological care as well. You observe this woman. Is this woman in pain? Is this woman happy? How is this woman feeling? You observe her by her reactions. And of course, in order for us to treat anxiety, suppose we're having a Miller and we see that the baby is clowning. The best thing that we do is we get the Miller and show it to the mother so that she can see her baby coming and even allow her to touch her at some point. All those things are going to be done during this second stage of labor, and we are going to manage her if we do so. She will be very, very happiest mother during that moment of labor. And once we are done with maternal observations, Also, what we do is fetal observations. So on fetal observations, we are going to record the fetal heart. We are going to use the fetoscope to record the baby's heart rate, and we need to keep in mind that during each and every contraction, the baby is at risk of distress or asphyxia, and this is mainly due to the compression of the cord as the uterus contracts. So we have to keep that in mind, of course. And once we are done with all this, we are now going to arrange our point. We say delivery of the age. We're still in the second stage of labor. We want to end this stage of labor with the delivery of the baby. So delivery of the age. How do we deliver the baby's age? Of course, we are going to deliver the baby's age slowly in order to avoid trauma on the perineum. We don't have to rush, but again, we don't have to be too slow. We just have to be in a medium. We do that slowly in order to prevent trauma to the perineal area. Once you see clowning, you can press your left hand inside and touch the baby's occiput. This is the occiput, to allow the small areas to distend the perineum. But as we do that also, as well as clowning takes place, you can make a decision as whether an episiotomy should be made or not, because that is going to be seen as the fetal age descends. And as well as that, you take it slowly. Once that is done, then you should allow also the sinciput of the fetus. This is the sinciput, the face and the chin, to sweep the perineum. Once they sweep the perineum, then they will be out. The head will be out. So suppose this is the vulva, and this is the head. The face, all of it is outward. What you do immediately, you are supposed to clean the baby's eyes, mouth, and nose. You clean them using a sterile gauze. You clean the eyes from the inside out. In case, and we do this in case the baby encounters any infection or microbacteria or microorganisms on the mother's vulva as it was descending, as it was sweeping the perineum. So you do all those things. In case there are a lot of secretions, you make sure you suction those, you remove them. That's why we need all the necessary equipment in the environment. Remember, we are talking about the environment being the labor ward. We need all those things that are needed to clean the baby, to take care of the mother in case any conditions arises. So in case there are any secretions, you clean the baby. And of course, when you are doing that, when you are removing all the secretions, you don't start from the nose, you start from the mouth. Then that's when you can come to the nose. So all those things you can do them when delivering the egg. Once you are done with the delivery of the egg, then the second thing that you're going to do is, of course, delivery of the shoulder, because you start with the head, shoulder, and the rest of the body. So what do you do when delivering the shoulder? Well, on the mechanism of labor, as the baby descends or as the baby is being born, it follows the 9 simple rules of mechanisms. It's going to be engagement, descent, internal rotations, all such kind of things. They're about 9. So when we are delivering the shoulder, we need to wait for restitution, both restitution and external rotation. And this will show, this is the only point that will show that the baby's shoulders are in the anterior posterior diameters of the birth canal. And this will be simple for us. So what we do is we are going to hold the baby on the biparietal eminences or in both head. So we are going to hold the baby like this. And then what we'll do, when we will start this by delivering the anterior shoulder. So we'll go downward and then we'll go upward and pull. That's the end of the delivery of the shoulders. So to deliver the anterior shoulder, we go downwards. To deliver the posterior shoulder, we go upward and then we pull. So we deliver the shoulders. What we are remaining with is the rest of the body. So delivery of the rest of the body. Also, the mother's abdomen follows what we call the curve of Callas. In order for us to do this, we are going to follow this curve of Callas. So this is what the mother's abdomen is more like. So in order for us to deliver the rest of the body, we are going to follow this. How do we follow this? Well, of course, we are going to go downward, upward, outward, and then pull. This is how we deliver the baby, following this, the curve of Callas. So downward, upward, outward, and pull. Immediately once you are done, put the baby on the mother's abdomen to promote bonding and breastfeeding. So you put the baby on the mother's abdomen to promote bonding. And after you are done with this, you do observations on the fetus. Sorry, the baby. It's no longer called a fetus, it's a baby, because it is born. So observations. Remember, we did observations when we were just starting, when the baby was still in the uterus. Have we seen the importance of observing the baby throughout? Even this time, we observe the baby. So you observe the baby on the upgastrol at 1 minute. The second thing that you are going to do, you are going to wipe the baby with a towel immediately it is born to prevent hypothermia. Once you are done with that, you are going to cut the umbilical cord. You press your forceps at around about 3 centimeters apart from the other side. You cut. And as you cut the umbilical cord, you don't have to hurry. You have to wait for at least 1 minute in order for all the nutrients that were retained in the placenta to go back to the fetal heart. Then you are going to do a very good job, because you are going to prevent this baby from developing anemia and all sorts of complications such as malnutrition. You do that as well. And then as well as that, after 5 minutes, you recorded the APGAR score at 1 minute. Then at 5 minutes, you also are going to do that. And once the baby is born, immediately again, you are supposed to palpate the mother's abdomen to rule out the presence of another fetus. If there is no any fetus and you are sure, the next thing that you are going to do is you are going to give symptometry or oxytocin to manage the state of labor actively, because that is going to promote uterine contraction. So we do that also as well in preparation for our third stage of labor. And the other reason why you are putting the baby on the breast to promote breastfeeding is that is going to cause the pituitary gland, the posterior pituitary gland, to produce an hormone called oxytocin. And oxytocin is a contracting hormone. So it's going to travel around the mother's blood and goes to the uterus. And what does it do when it goes to the uterus? It will cause uterine contractions, initiating the third stage of labor actively. Don't forget to show the baby to the mother. How you do that is you ask her, what baby is this? Is this baby a male or a female? And then they will say it. And once you are done with that, you put the baby, you wrap the baby, and you also put an identification band, all sorts of things. You write the name of the mother, the date and time the baby was born, and the code. The next thing that we want to talk about now, we want to look at how we can manage the third stage of labor actively.